So just a disclaimer, I work for the federal government, and nothing I say reflects the position policy of the Department of Veterans Affairs or the U.S. government. Thank you very much. So a little bit about physician-assisted laws in Oregon and the United States. The Oregon Death with Dignity Act passed by popular vote. It was a squeaker, 51 to 49% in 1994, but then there was a series of challenges, a second vote, and it was finally enacted in 1997. And Katrina Hedberg and David Ortlinker will both be talking about the structure of these laws more. For 14 years, Oregon stood alone. I thought it was just going to always be one of these quirky Oregon things. But then in Washington passed the law in 2008, Vermont in 2013, and then very quickly in the last couple of years, California, Colorado, and Washington, D.C.'s. And all these laws are almost identical to Oregon. So currently, by my back-of-the-envelope calculation, over 60 million people now live in a jurisdiction in the United States where physician aid in dying is legal. Montana does not prosecute physician aid in dying for competent terminally ill patients by a judicial decision, and I know nothing else about what's going on there. So these laws allow a patient to receive a lethal prescription from a medication from a physician if they are competent, terminally ill, and it's for the purposes of self-administration. A second physician has to confirm that. Patient has to be informed of all feasible alternatives such as hospice care. If there's concern that a mental illness such as depression is impacting the decision, they have to be seen by a psychiatrist or a mental health professional. Physicians are not required to participate. These laws do not allow a lethal injection by others or physician aid in dying by advance directive. And physicians who prescribe are required to notify the state, some kind of state legal entity, and provide documentation that the legal requirements have been met. Now, in Oregon, there's several sources of information about the law. The most comprehensive is the Oregon Health Division reporting system. It includes all legal cases. If it wasn't reported to the Health Division, it wasn't legal. There's a high degree of confidence about the demographic data. It continues to be updated yearly, and it allows comparing PAD deaths to all other deaths in Oregon. The limitations are that the information about patients is through their physician, so it's a secondary source. There's a lack of detail. I have conducted a series of research surveys. This includes information directly from patients and families. This allows for greater detail, and it can be used for hypothesis testing. But because not everyone who's invited participates, there's always the question about what motivates some people to participate and not others, and that's called selection bias. And that can limit the generalizability. And my studies are now 10 to 20 years old. I don't think they're stinky old, but they're definitely, our country's changed. And so I don't know if the data has changed. In addition to research surveys, there's the opportunity for research qualitative interviews. And these can be used to generate hypotheses. So if you're not sure what's going on, that's a great way to do that. They allow vivid descriptions of participants and experiences. And in my, you can tell an audience about patient characteristics, but then when you describe them from the qualitative interviews, that's when people get that aha look. And it can be used to support qualitative data. The limitations that it by nature lacks generalizability, there's more risk of bias, and there's a limited ability to compare and contrast. So these are some of the studies I've done of Oregon psychiatrists, psychologists, a study of all eligible physicians in Oregon who by 2005% had received a request for physician aid in dying. A study then of hospice nurses and social workers in 2002, who at that point almost a third had cared for a client who had received a lethal prescription. The advantage of hospice nurses is they actually see patients. These patients in the last few weeks of life frequently, have discussions with them. They're probably, forgive me, physicians in the audience, they're probably more psychosocially attuned to their patients. And they don't have as much reason to represent patients as looking a particular way as prescribing physicians might. Later, I presented this material to a hospice group, and I was ambushed by the hospice chaplains who said, "Why don't you survey us?" I got some of the most amazing qualitative material from them. All of these surveys have response rates of over 65%, which encourage us to think that they might be generalizable. And most of them were followed by qualitative interviews. In addition, a study of 56 Oregonians who had explicitly requested physician aid in dying, and a series of measures, and then another study of 95 family members for a patient who had requested physician aid in dying, about 14 months after the patient's death. And of those, 59 had received a lethal prescription. So what do Oregon healthcare providers think of this law? Again, this is older data, some of it 22 years old now. We don't have anything more recent. But in general, physicians and hospice nurses are divided in the law, with about half of them supporting it, a core third opposing it. Hospice social workers, much more supportive, again, potentially reflecting their education in client autonomy. Hospice chaplains, surprisingly divided, with at the same number supporting as opposing the law. Psychiatrists who have long history of fighting suicide, but over half would supported this law, and psychologists overwhelmingly supporting the law. One of our first studies was a survey that went to 4,000 Oregon physicians. We got about 2,600 responses. This was in 2002, and by then, 143 physicians had received a request for a lethal dose of medication. And about 1 in 6 requests resulted in a medication prescription. At the time of the first request, about a third of the patients were already in hospice. 3/4 had a life expectancy of less than 6 months. 59% were confined to bed or chair over half of their waking hours. In about almost half of the cases, the physician responded by implementing a substantive palliative intervention, treating pain, sending the patient to see a mental health professional. But by far the most effective intervention was referral to hospice. And in about half the cases where they did that, and it was mostly hospice referral, the patient changed their mind about wanting physician aid in dying. Physicians were more likely to prescribe if they were not in a small town. There's quite a bit of information about the lack of access in rural areas of Oregon. If the patient was already enrolled in hospice and they wanted to control their death, they were less likely to prescribe if the patient viewed themselves as a burden or had symptoms of depression. About a third of Oregon physicians were willing to prescribe under the law. Among hospice nurses and chaplains, only 3% of hospice nurses and 14% of chaplains would actively oppose a client's choice for physician aid in dying. And 12% of nurses and no chaplains would transfer the patient who received a lethal prescription. And I think this reflects the much higher ethical focus on non-abandonment among hospice providers. And 90% of people who die in physician aid in dying in Oregon are hospice enrolled. And that's important because really, even among those who support the law, there's this general agreement this should be an option of last choice. It shouldn't be the option before other things have been tried. In all my studies, I measure religiousness just on a 1 to 10 scale, where 10 is religion is very important to my life, 1, religion is not important in my life. In Oregon, hospice nurses, caregivers of ALS and cancer patients come in with a mean score of 6 or 7, but requesting patients had a mean score of 2.3, the lowest score of any group we've ever measured it. And so showing that religiousness probably protects one from pursuing physician aid in dying. This probably is one of the reasons Oregon was the first state. Oregon vies with Nevada in most surveys as being among the most unchurched of all the states. In addition, in most of these studies, we measure spirituality on the same scale. 10 is spirituality is very important. And in Oregon, no matter who you ask, the mean is a 9. And the standard deviation is from 8 to 9.5, showing that no one in Oregon would ever admit to not being spiritual. And so we just dropped that measure because it just wasn't helping us. But in another measure of spirituality, when we looked at requesting patients and compared them to terminally ill patients who had not requested physician aid in dying, low spirituality has measured on the FactSet spirituality subscale, which is a combination of meaning, hope, and purpose, is the strongest predictor of physician aid in dying requests. In addition, there's this concept of one of the ways of measuring personality is through what's called attachment. And I won't go into this too much except to say there's an attachment style called dismissive attachment, which is really characterized by this lifelong value on self-sufficiency and independence. And patients who want physician aid in dying are much more likely to have this lifelong personality characteristic. Let me just skip that one. One of the concerns about physician aid in dying is that it is a form of suicide. And what we know about suicide is that the biggest risk factor are mental disorders, particularly depression and substance abuse, are found in about 80% of all suicides. So the question would be then, how much does that impel patients who want physician aid in dying? And the results are a little mixed, and they're not quite clear to me. In the Oregon hospice practitioner study, social workers were asked to rate on a scale of 1 to 5, where 5 is a very important reason for requesting physician aid in dying. 1 is not important. And they rated it as a 1. And they have a lot of clinical experience. So they did not feel that patients were asking for physician aid in dying because of depression. In our study of patients, about a quarter met criteria for significant clinical depression. And within that, about half of them felt that the depression was influencing their request. So remember in these laws that not only that what may exclude you is not having depression, but depression that a practitioner says is influencing your decision. I've never really figured that one out. And among these 15 patients, 3 of them received lethal prescriptions and did not have a mental health evaluation. But even then, it's confusing. 2 of them said they didn't think the depression was influencing. 1 of them did. 1 of them got depression treatment, clearly had a remission of depression, and still chose physician aid in dying. So I've talked about a lot of factors that were not as important as we thought they were going to be. We thought that when the law passed, that people who make these requests were people who weren't accessing good end-of-life care, people who were socially vulnerable, and found really the opposite. But one of the strongest predictor of people wanting physician aid in dying was how important control was to them. And in the hospice nurse study, again, on this 1 to 5 scale where 5 is very important, We see the median for controlling circumstances of the death is 5. The interquartile range, the 25 to 75%, is 5. 85% of hospice nurses said this was the most important reason people chose physician aid in dying, followed by wanting to die at home, fear of loss of independence, and loss of dignity. In addition, that's what patients said. They rated wanting to control the circumstances of death as a 5, and most of them picked that out as the single most important reason. Also rating highly loss of independence, inability to care for self, not wanting to be cared for by others, and wanting to die at home. All of those in the future, because at the time we saw them, they were not experiencing those factors. From the qualitative interviews, these are descriptions from physicians about, where am I? Am I done? About these patients. An example, one physician said, these were individuals who wanted to control their lives, and it was mostly a control issue. And they sort of stated that right up front. It had nothing to do with the care they were getting. They would return to it and return to it. And you could say, you know, we're doing all we can, and we're making this commitment to you, and we're trying to take care of you. But they sort of fixated on ending their life from the get-go. Another factor that has come up is that patients not wanting to be a burden to others. The patients themselves rated that as important, a median of 4 on that 1 to 5 scale. But of interest, hospice nurses said these patients, in general, the family members, compared to other hospice patients, found more positive care, meaning felt less burdened by the care and felt much less burdened by the cost of care. The patients themselves said that financial concerns on the 1 to 5 scale was a 1. They were not motivated by finances for physician aid in dying. A little bit about the families. We looked at mental health outcomes. Suicide in a family is associated with a strong sense of shame, rejection, stigma on the part of family members. And the question is, how much is physician aid in dying similar to that? We found no difference between PAD families and comparison families in major depression or prolonged grief. There was no difference between physician aid in dying families and comparison families in how much peace they felt with their at the end of life choices, being burdened by the care, be included in the decisions, accepted the loved one's death. Again, that's all very different than suicide. Of interesting, the physician aid in dying patients families indicated they feel much more prepared for the death. And then when we compared those families where a prescription was obtained versus those where it wasn't, those who did not get, where the prescription was not obtained, had much more regret about how their loved one died, and were less likely to indicate they felt that the patient's end-of-life preferences were honored. So in summary, I think the primary reason Oregonians request physician aid in dying is to increase their sense of control and avoid dependence on other people. And this is a lifelong value. This is not something that occurs at the time of terminal illness. And I think there's strong evidence for this. That's what everyone who saw the patient agreed with. The patients agreed themselves about this. Patients are more motivated to request physician aid in dying because of worries about symptoms in the future, not the symptoms they're experiencing at the time of their request. Around 25% have clinical depression, but it's unclear to me how much that is influencing their request. And pursuing physician aid in dying is not associated with increased risk of adverse mental outcomes for family members. Thank you.